Welcome to our second and last video on bradyarrhythmias. Let's begin. In this lecture, we will talk about the atrioventricular blocks. In AV blocks, we will discuss the first-degree AV block, second-degree AV block, Mobitz type I, Mobitz type II, and third-degree AV block. We will discuss the different degrees of AV blocks together because there is significant overlap between these conditions. We will also emphasize the differences between them on the way. We will discuss the definition, causes, clinical presentation, diagnosis, and management of AV blocks. First-degree AV block is characterized by delayed impulse conduction through the AV node. In contrast, the second-degree AV block, Mobitz type I, also known as Wenckebach, represents the progressive delay in impulse conduction through the AV node with a dropped beat. In other words, these two diseases typically arise at the level of the AV node. The second-degree AV block, Mobitz type II, represents the intermittent disruption of impulse conduction through the His-Purkinje system. In contrast, the third-degree AV block is due to complete disruption of impulse conduction through the His-Purkinje system. There is complete AV dissociation in the third-degree AV block. In other words, atria and ventricles depolarize independently. Both second-degree AV block, Mobitz type II, and third-degree AV block classically arise below the AV node. AV blocks can be caused by multiple different conditions. First, ischemic heart disease can induce AV block, especially if atherosclerosis affects the posterior descending artery. This is because AV node is supplied by posterior descending artery. Infections such as Lyme disease can also cause the AV block. Lyme disease is usually associated with third-degree AV block. Cardiomyopathies cause stretching of the conduction system, resulting in AV block. Cardiac surgery can cause AV nodal fibrosis, resulting in any degree of AV block. Finally, AV nodal blocking agents may significantly delay impulse transmission from the atria to ventricles. These agents include beta blockers, non-dihydropyridine calcium channel blockers, digoxin, adenosine, and amiodarone. First and second degree AV block, Mobitz type I, also known as Wenckebach, are usually benign and asymptomatic. In contrast, the second-degree AV block, Mobitz type II, and third-degree AV block can cause symptoms due to decreased cardiac output and oxygen delivery. These include fatigue, shortness of breath, lightheadedness, and syncope. Patients may also experience exercise intolerance and ischemic chest pain. Ischemic chest pain occurs due to decreased coronary perfusion. Diagnosis of the AV blocks is based on the combination of patient symptoms and electrocardiography finding. We will talk about specific ECG findings characteristic of AV blocks in the next few slides. We should also inquire about the medication history to check if the patient is taking AV nodal blocking agents like beta blockers or non-dihydropyridine calcium channel blockers. Characteristic ECG findings in first-degree AV block is prolonged PR interval. Normally, PR interval should be anywhere from 120 to 200 milliseconds. In first-degree AV block, PR interval is more than 200 milliseconds. Characteristic ECG findings in second-degree AV block, Mobitz type I, is progressive PR prolongation with a dropped beat. Dropped beat is the P wave not followed by QRS complex, and it signifies complete disruption of impulse conduction through the AV node. Hallmark ECG finding of Wenckebach is regularly irregular rhythm. In other words, RR intervals are different, but there is a regular pattern which is repeated over and over again after each dropped beat. This is what ECG looks like in first-degree AV block. Please note the prolonged PR interval of 0.38 seconds or 380 milliseconds. Normally, the PR interval should not be more than 0.2 seconds or 200 milliseconds. This is what ECG looks like in second-degree AV block, Mobitz type I. Please note progressive lengthening of PR interval. In other words, every RR interval is longer than its previous RR interval until the beat is dropped. As we already mentioned, dropped beat is the P wave, not followed by a QRS complex. A 72-year-old man with congestive heart failure presents to the physician with complaints of shortness of breath, exercise intolerance, chest pain, and 3 episodes of syncope over the last 2 months. Echocardiography shows no valvular lesions. ECG is performed. The physician diagnoses him with second-degree AV block, Mobitz type I. Which findings are expected on the ECG of this patient? This patient presents with complaints of shortness of breath, exercise intolerance, chest pain, and 3 episodes of syncope over the last 2 months. the physician diagnoses him with second-degree AV block Mobitz type 1. As we already mentioned, this type of AV block is typically asymptomatic. However, if the patient has other cardiovascular comorbidities like heart failure, second-degree AV block Mobitz type 1 can present with symptoms of bradycardia. Classic ECG findings of second-degree AV block Mobitz type 1 include regularly irregular rhythm and progressive PR interval prolongation followed by dropped beat. Characteristic ECG findings in second-degree AV block Mobitz type 2 is the dropped beat without progressive PR prolongation. In other words, RR intervals are of the same length from one beat to another. PR interval itself can be either normal or prolonged. Please keep in mind that second-degree AV block Mobitz type 2 has the risk of progressing to the third-degree AV block. This is what ECG looks like in second-degree AV block Mobitz type 2. Please note the RR intervals are the same length from one beat to another until the beat is dropped. PR interval is normal. As we already mentioned, the drop beat is the P wave, not followed by a QRS complex. A 52-year-old woman comes to the physician reporting shortness of breath, exercise intolerance, and 4 episodes of syncope for the last year. Echocardiography shows no valvular lesions. ECG is performed. The physician diagnoses her with second-degree AV block Mobitz type 2. Which findings are expected on the ECG of this patient? This patient presents with shortness of breath, exercise intolerance, and 4 episodes of syncope over the last year. The physician diagnoses her with second-degree AV block Mobitz type 2. Classic ECG findings of second-degree AV block Mobitz type 2 include dropped beats and normal or prolonged PR intervals with no progressive lengthening. There are several characteristic ECG findings in the third-degree AV block. First, atrial rate will be higher than ventricular rate because atrial pacemaker is inherently faster than the ventricular one. Additionally, there will be regular PP and RR intervals. This is because atrial and ventricular pacemakers fire after predetermined regular refractory period. Finally, P wave might coincide with the QRS complex or T wave. This is what ECG looks like in third-degree AV block. Please note that PP intervals and RR intervals are regular. In other words, they don't change in length. We also see P wave on T wave. Typically, no treatment is required for first-degree or second-degree AV block Mobitz type 1. Pacemaker is usually not indicated either. A 62-year-old woman comes to the physician for a routine checkup. She has no complaints. ECG shows PR interval with a length of 320 milliseconds. What is the next best step in management of this patient? This asymptomatic woman has prolonged PR intervals on her ECG evidenced by PR interval length of 320 milliseconds. This presentation is consistent with the diagnosis of first-degree AV block. Since first-degree AV block is typically benign and the patient is asymptomatic, the best next step in the management of this patient is reassurance and observation. In contrast, we need to treat the second-degree AV block, Mobitz type 2, and third-degree AV block. If the patient is hemodynamically unstable, then one should administer atropine and start transcutaneous or transvenous pacing. If the patient is hemodynamically stable, then the implantation of permanent pacemaker is indicated. Here's a table summarizing everything that we have discussed in this lecture. Pause the video and take a moment to consider the table. A 75-year-old man presents to the office with shortness of breath, exercise intolerance, and fatigue. He has past medical history of disseminated Lyme disease. He has been smoking 2 packs of cigarettes per day for the last 40 years. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 115/70, heart rate of 37, and respiratory rate of 18. ECG shows regular PP and RR intervals with no temporal association between P and R waves. Echocardiography is unremarkable. Which of the following is the best next step in the management of this patient? A. Temporary pacemaker. B. Permanent pacemaker. C. Phenylephrine. D. Observation. This patient presents with shortness of breath, exercise intolerance, and fatigue. His past medical history of disseminated Lyme disease suggests the possibility of Lyme carditis. Heart rate of 37 beats per minute is consistent with severe bradycardia. ECG shows regular PP and RR intervals with no temporal association between P and R waves. These findings on ECG are consistent with the diagnosis of third-degree AV block. The next best step in management of the patient with third-degree AV block is implantation of a permanent pacemaker. So the correct answer is option B. Here's a slide reminding us of the management of third-degree AV block. Let's discuss why the other options are incorrect. Option A is incorrect because patients with third-degree AV block need permanent rather than temporary pacemaker. Option C is incorrect because phenylephrine is a vasoconstricting agent capable of causing reflex bradycardia. Reflex bradycardia would further exacerbate this patient's third-degree AV block. Finally, option D, observation is incorrect because this patient is symptomatic from the third-degree AV block and needs prompt treatment. And that concludes our lecture on bradyarrhythmias.